So I began recording. One of the biggest questions that keep coming to me is, sir, is there a 3D model that you can provide so that we can visualize things using the 3D model? Okay, this is a very common question that I come across. Okay, is there a 3D model that we can visualize? And the idea is, okay, if there is a 3D model, we can visualize better how the debris is going to move with each maneuver and all of those things. 3D model itself can take us to a certain level only. Beyond that, 3D model will not help. Okay, in the beginning stage, okay, if you want to imagine how exactly the debris moves and all of those things, a 3D model will help. More than a 3D model is a projection of the semicircular canal anatomy from the frontal plane, from the lateral plane, and from the top that really helps us in identifying what nystagmus to expect in different locations in a particular location, and gives us the power to actually come up with the best maneuver that is suitable for somebody, and to come up with newer maneuvers which are no longer there to take care of some of the recalcitrant cases. So this is the idea. Last time when we saw, I introduced this concept of, last time I introduced this concept of the belt drive mechanism. Okay, the belt drive mechanism is what I introduced last time. So using the belt drive mechanism and knowing the frontal projection of the semicircular canal, the lateral projections of the semicircular canal, and top projection of the semicircular canal, we can do a lot of things which would not be possible even with a 3D model in your hands and putting the patient into different positions. Okay, so I'll just start sharing my screen to demonstrate this particular principle to you. Hope you are able to see my screen.
Yes, sir, we can see it.
So when I say a 3D model, rather than a 3D model, a projection of the semicircular canal anatomy from the side, a projection of the semicircular canal anatomy from the front, and a projection of the semicircular canal anatomy from the top will help us a lot into finding out what kind of debris movement is possible in different kinds of tests. So here I've just projected the anatomy from the side. Because it is from the side, there is no really need to bother about it is the right or left or whatever. One side, both sides is fine. So what you see here, if you can see my arrow, this is the anterior canal and this is the posterior canal. This is the common crus. And this one itself is the lateral canal. And this one itself is the lateral canal. So when the person is upright, the entire structure of the lateral canal is almost in one plane. So not much of movement of the debris is expected. In the anterior and posterior canal, they seem to be head on or face on with this. And when the person pitches forward or pitches backward, at that time, what kind of movement is expected? Okay, even in the lateral canal, what kind of movement can be expected? With all of those things, we can see. Okay, so this is one anatomy from the lateral aspect. Now, in the lateral aspect, when you see, if you just go to the previous, just let us imagine, here you see the ampulla of the posterior semicircular canal. This concavity within that, like a cookie bite, whatever you see, is basically the crista of the posterior semicircular canal. Most of the time, the debris that settles down and goes will go and lie in this flat part of the posterior semicircular canal. So this is what happens. Okay. Now in the anterior semicircular canal also, when it goes far beyond, it will go and settle somewhere here in the rising limb or just below here in the anterior semicircular canal. Now if you mark these two areas, and then if you see what happens in the typical Dix-Alpine position when the head goes below the couch by 45 degrees. You can see here both locations, the anterior canal, the deepmost part. Okay, when you see the anterior canal deepmost part, I was talking about this area. Ma'am, just confirm that you are able to see my cursor. Otherwise, I'll use some other pointer. Okay.
Yeah, we can see your cursor, sir.
Super. So if it was here, just see what will happen in the Dix-Alpine position. You know, in the Dix-Alpine position, the gravity will work downwards and this has to start moving down. And when you see the posterior canal also, okay, if you see the previous slide, in the posterior canal, if the debris was somewhere here, okay, if the debris was somewhere here, now when you take the person into the Dix-Alpine position, now this is gravity dependent and it starts moving downwards. Up to where it will move up to here. This one will move up to here. So it will take to a certain extent, it will take all the way down. But now there is going to be a stage where it can go back, or it can just go back into that place, or it can be pushed. This is the next important thing that is important, how we plan this. Okay. So it can come all the way up to here. It can reach up to here. This can come all the way up to here. It can reach up to here. If the patient from here comes to the upright position, okay, back to the upright position, just imagine the anterior canal. This is the topmost part. I mean, this was the previous topmost part. Here it reaches almost up to here. Now in this anterior canal, from this position, if the person, from the full Dix-Alpine position, if the person is brought to upright position, what would happen to this guy? Okay. Okay. So if this had crossed this particular doom in the previous step, if this had crossed this particular doom, and in this position, it would have crossed this particular doom, and it is expected to reach up to here. If it crosses up to this part in this particular position, then taking the person into the upright position, if it had crossed this part, this is the topmost doom, and it had come up to here, then in the upright position, it is expected that this particular individual, just with a Dix-Alpine maneuver, taking the person down and then raising him, should be able to solve the problem of the person. The anterior canal BPPV should just settle with a Dix-Alpine maneuver if that was the case. But the problem is that is not the case. The reason here is up to here, it is a big fall. It's a vertical fall. After that, it is a slide. So if you see waterfall or whatever you throw from the top of a slide, it is easy when it is vertical, it will jump all the way. But here, though this is the dependent most part, it may not reach the dependent most part, but because this is a slide, and it can still reach somewhere up to here. The moment it starts becoming a slide, it will just stop somewhere. Therefore, even if the patient after this gets up also, okay, if the patient gets up also, it would not have reached this doom, and it will start going back. The key concept here is, in every position that we do, there is a doom or the topmost part, and that topmost part has to be crossed in the next position. Only then the further position will be beneficial. So now when you take this person from this position, anterior canal, only if it does not cross this doom, then in the same position, when you go back to the same position, it will just fall back. It will not be curative. So our idea here should be that to make sure that once it reaches here, it actually crosses the previous doom part, that when the person comes to the upright, its route is coming back. So it becomes very obvious how do you do it. You do it by lifting the chin up. I'll just take that amount of freedom. Okay. You will do it by just lifting the chin up. After this maneuver, if you just lift the chin up like this, now what would happen is, now from this position, I do most of it is on the go, my thought process and all these things. Okay. More of a blackboard teacher I am. So now when you lift the chin up, then even if it is not crossed, then it will start. This part becomes vertical and then it starts falling. This part starts becoming vertical and it starts falling. And in the next step, when it starts falling like this, and in the next step, when you make the person sit up, it will just go and fall like this. So this is the reason why those, if it was otherwise, if things were really moving to the full, okay, if the things were really moving to the full, okay, if the things were to move fully to the lowest part without any problem, then just the Dixalpike would have been curative. Just the Dixalpike. Because the moment you put the patient down, all the debris would go all the way to the lowest part. And this lowest part is still high. And when the person is made to come up again, from this part, it would have simply, okay, from this part was the lowest part. From this part, it would have simply slided down. But unfortunately, that is not the case. So because of that, we need to, at every point of time, make things slide at every step. And that is why this particular thing is important. This has been demonstrated. If you see Dr. Michael Strupp's lectures, there is a particular simulation that they have done why this does not reach the lowest part. Why this particular thing does not reach the lowest part. A solid in a viscous fluid that it need not fully, and in a narrow tube, okay, they have done a simulation, and then there he's very fond of showing that particular animation where it stops short of the lowest part. It just comes up to a certain point and then it stops short of the lowest part. So because of that, these intermediate steps are very important. So when you take the person into a Dixalpike or even more extended position, it will go all the way down. But when you are coming back, you need to wait for that to, if it has not crossed the doom, the uppermost doom, which is likely to be the doom in the next position, then if this is going to be the doom, if you are taking the person into the upright position, okay, if you're taking the person into the upright position, that would have been the doom, and if it had not crossed that, it will fall back. This is the key concept. To ensure that it actually passes that, we need these intermediate steps. Okay, we need these intermediate steps. From this step, you can lift up the chin and then make the person sit up. If you want it to be even more effective, in between lifting up the chin, it is very obvious from now only that you can even keep the person in the supine position for some time so that some more debris can move. So you take the person as much possible as backwards, even more backwards also, okay, if the neck allows. Then you can bring the person a little by little into the upright position, little by little into the upright position, so that there is enough time for the debris to move and then come back. Finally, when you see here, you see this particular thing, this particular area, when you see here, is still in a slant. If you want this falling to be even better, what you can do is, that is much this thing. So if you want this to be even better, what you can do is that you can make the nose tilt forward. So I'll show that. You can make the nose tilt forward. So when you make the nose tilt forward like this, then what will happen is debris will simply fall off. So this is the beauty of this particular maneuver, what we call as the Jacobino maneuver, going by this thing. So the key message here is, though theoretically the lowest part can be achieved, just the Dick-Salpike test should be able to solve. Dick-Salpike test itself should be able to solve a anterior canal BPPV. It really does not happen because the topmost doom in the next part, okay, the upcoming step, topmost doom, would not have been crossed in the previous step. Okay, would not have been crossed in the previous step. Okay, so that is what is the most key point. Okay, if it had crossed, the debris had crossed in the previous step, the topmost part of the doom that is going to come in the following step, then it will definitely have come. Okay, so that is the key message here. Now, all of us know for the anterior canal, for the posterior canal. Now, when you look at the posterior canal, okay, which is more common. Okay, when you look at the posterior canal, the debris will be somewhere here. And when you do the Dick-Salpike test, the debris will go like this. Okay, the debris will go like this. Now, the lifting up the head from here, which was so elegant for anterior canal, suddenly becomes a limitation for posterior canal. Just see this. Now, in the anterior canal, what was so, from here in the anterior canal, the debris had reached all the way up to here. Now, lifting the nose up, the head up, would have made things go down like this. Further up would make things go like this, and then it would make the things fall. So beautiful for the anterior canal. But what will happen for the posterior canal if you directly lift it up? What will happen to the posterior canal? So in the Dick-Salpike position, okay, in the upright position, the debris is somewhere here. In the Dick-Salpike position, the debris starts moving like this, and then it goes up to here. Now, if you lift up from this position, if it had not crossed whatever, then what will happen is, it will start going back. Okay, it will start going back, and then if you make the person sit up, it will again go back. This is the problem with the posterior canal. So what worked for posterior canal, for anterior canal, just going up and then going as extended as possible and then lifting from there, worked so well for the anterior canal, but will not work for the posterior canal. So what can we do for the posterior canal? I am sure by now you all have guessed for the posterior canal what we are supposed to do to ensure that this thing is taken care. So if you have guessed, it's fine, but otherwise I will just demonstrate that to you. For the posterior canal, what you are supposed to do. Okay. For the posterior canal, what you do is, in the first upright position, okay, in the upright position, from the upright position, you take to the Dick-Salpike position. From the Dick-Salpike position, you do an intermediate step, but finally what you do is, see here, please trace the debris was here. When you take into the Dick-Salpike position here, the debris starts moving all the way down here to whatever extent it starts moving. Now, you just make opposite. Okay, so just make opposite. So the debris had moved somewhere here. It had crossed this point and it has crossed and it is gone up to here. See, please notice this particular square cut here. So it crosses the square cut and it comes towards the common crest, okay, in this direction. When the nose is up in the Dick-Salpike position. If you suddenly turn the nose down by making the patient just prone and the nose looks down, then what will happen is, see, this part has crossed. So this part, it had crossed and it was somewhere here, the debris. So that it is somewhere here. Now you see, in this position, the debris will start gravitating even further down. The more you do, even better. There's a small problem that can happen in this semi position. The small problem that can happen in this prone position with about 45 degree, that one is The good thing is the debris will not move like this so easily, okay, because it only goes up to the more in the vertical parts, okay, in this. And but if by chance it goes here, there is a possibility that it will enter the anterior canal. There's a small possibility, but that is, though there are reports, there is a Shigino paper that is written that it can enter and all of those things. Still, okay, still, but even if it enters also, there is a solution. I'll come to that later. But when it comes to like this, there is a possibility. But if you overdo it, then the doom, the lowest part, the doom or the lowest part will still be above the entry into the anterior canal. Therefore, it will not fall. Okay, therefore, it will not fall. But that is fine because anterior canal entry is not a great sin or anything, because that can be handled within the next step. And how to identify and how to handle, I will deal with in the next part of the section. So when you see this one, when it comes here, it will start going, or you can overdo this. And from here, again, you start lifting the head up. Once you start lifting the head up, this will fall back. Just for you to visualize, I will do that also in the next slide. Okay. I'm more of a blackboard teacher, so I think as things happen. So from here, again, what you can do is you can start lifting the head up. Okay, that will be our positions. I'll delete this, I'll delete this. So this was the previous position. Now you can, or the full lowest position. From the lowest position, you can start lifting the head up. This is the next position. Then, so now what will happen is, it would have gone all the way up to here. It would have reached, but it cannot enter the flat part because you know that viscosity thing. From this position, you can simply lift the patient up. Okay. Now into the supine position. Now it will start falling like this. And from this position, again, lift the patient up. From this position, you make the patient to, I'll just draw these things aside. From this position, when the head is upright, from this position, just make sure that the person is lifted up with the nose down. Just lifted up with the nose down so that the last part becomes vertical and the head starts falling down. So just to reiterate so that all of us are in the same page, what you do for the posterior, for the anterior canal, you saw, just to reiterate for the anterior canal, in anterior canal, it is so beautiful. You take the person from this position into the most extended position, that is the Tick-Salpike position. All the debris will start going down. From there, you start lifting the patient up and then make the person sit up and then make the person put the nose a little front and the debris will fall off. When it comes to posterior canal, what we do is, from here, we take the person into the Tick-Salpike. After the Tick-Salpike, what we are supposed to do is put the person into the nose down position so that from now onwards, lifting up happens in an opposite way. Rather than in anterior canal, lifting up happens in a certain way. In the posterior canal, the lifting up of the chin happens in the opposite way, so that progressively things will start getting emptied. So you can go into this position or into this position. The more you do, the better. And then from there, from this position, you start lifting up so that it starts moving. Then you make the person supine like this. This debris starts moving like this and sit up. Okay. And make the person sit up so that the debris finally sit up with the nose pitched down. This nose pitch down, a little bit of nose pitch down, that is about 30 to 40 degrees down, is so important both for anterior and for posterior, because that is the step at which the common crus is That is the step at which the common cross is most vertical. Okay, most vertical. So far, are there any questions? Based on that, I will go further to solve some confusions that usually happen and some of the things that we should expect. Okay, I'll stop sharing right now. If there is any question, I will answer that. And then again, I will come back to this.
Hello.
Yeah.
Sir, so you mean to say that to summarize, in a canal we add the chin up and finally nose down, and in the posterior canal we add just nose down while coming
Yeah.
from the distal pipe.
In fact, I can play a video for you.
Definitely, sir.
Okay, I can play a video for you for the for the this thing. Okay. Just give me a minute. I'll just play the video for you. Okay. I'll fetch the video. I'll fetch the video and I'll get it for you. Okay. And I'll play before that. Any question other than that? Yeah, I got the video. Yeah.
There are some more questions in the chat box.
Yeah, please. I will just see. Yeah. I don't see many questions. Yeah.
So for posterior canal.
Yeah.
Sir, for posterior canal, till the patient comes to horizontal level, he will be in supine posture. After that, he sits and then we have to flex the neck forward.
I will show you my method only, sir. Okay, I will share my video right now. Okay.
Okay.
So that there is no doubt about how I am doing it right now. Okay.
No,
and we are been treating with this method and we were struggling before. Okay. Now we are actually getting better results. Of course, it is too early to make big claims, but we are getting a bit better results than before. Okay. I'll just optimize for video and reshare. Done. So I hope you are able to see this. Okay.
So this is how I'm going to do the.
Yes, sir.
You are able to see, right?
First thing to give.
Yes, we are able to see.
Couch here. Couch is just 1.5 feet height above the ground. On top of that, there is a 4-inch mattress. This is very important because patients feel very confident and comfortable in a low height couch. This can be 2.5 feet. You start from one edge of this 2.5 feet couch, so that when you roll over, you have enough margin. Then person sits little closer towards this edge, not in the center.
So this is the couch that we need to use. And we start from one edge of the couch because when the person rolls over, there should be enough space. Now we take the person into this distal pike position. That is the first position. Okay. I usually do it with a chair. It is not that I am damaging my back. I don't do that. Here, this is my office. I have recorded this on a little urgent basis. Otherwise, you have to use a. So, first step is actually going into the distal pike position. People actually tend to hold the neck tight. You have to give them more and more reassurance and tell them, I will hold your neck weight. and then
That's
allow.
where you
In the
go
next step, I skip the second step. You must have noticed here.
down.
I just skip the second step and straight away go to the nose down position.
Again,
Okay. See this.
so that the debris goes gravitates.
Okay. As much as possible extension here.
Then
And in the next
this
step,
position for 60 seconds. After this position has been maintained for 60 seconds with the head being supported,
yeah.
you can tell the person not to hold neck tight.
Okay.
Leave the weight in your hand so that what happens is there can go.
From
Because
here,
the position is
straight away I go to the next position.
this way. I skip that. Straight away progress to steps where you'll go over to the other side. And you can notice
And nose down position. And in fact, I pitched the nose even further down. He was little not that compliant because he didn't understand and we did this shooting in one go. But he was a nice gentleman. He came there as a volunteer immediately to. Then the nose down.
But they have been ready to sit down.
Okay. Then we give them instruction that they have to be ready to sit up. Okay. Keep the legs here. And then we keep the nose down.
Keep the head
Okay.
down. Nose a little bit down.
Next thing what we do is we have been doing this for multiple years is that make the patient jump in place.
Sit
Okay.
down.
So with the nose down, we make them get up
Yeah.
and we make them jump in place without lifting the head.
One jump.
Okay. You can wait before the step is done on the couch only because some people, okay, they will have a retropulsive fall after sitting up. So wait for the retropulsive fall time to get over. After that only do this. I hope the method is clear. Okay. So the key thing here was when it comes to anterior canal, the key thing here was when it comes to anterior canal, the Iacoviano method of going back and lifting up progressively brings the debris this way. When it comes to posterior canal, the lifting up has to be from the prone upwards. For anterior canal, it was from backwards up. But for posterior canal, it has to be down, up. Okay, so this is the key message that I wanted to demonstrate through those images that I showed you. Okay, so that is the image, and that is why I showed you those things. Okay, there are some questions. We add chin up. Yes, that is the entire idea. We need to add the chin up. Okay, you can come to supine, add the chin up, and then make them sit up. Ideally, that should not be required. If you just simply do a gravity-based simulation without taking into consideration the viscosity, then you will simply tell the chin up step is not required. But if you see here, and if you see the simulation that Dr. Stroop shows and all of those things, when you see that, you know the importance that there is something called viscosity there. It doesn't actually reach the most dependent part, which means you need to hold it as vertical as possible, and then go into the next steps. Okay. Fine. So now there are some retesting questions and all of those things. I will deal with them again. Okay. Now, how long the person should be kept in each position, these things. Now, the question about how long to keep in each position, all of those things is again one more question. I will show you, okay, how much time in each position. I will show you all that. Okay, right now I will show one video which will answer to some extent what exactly happens. Okay. Again, I will share my screen to demonstrate exactly what I showed here, similar thing being done, but then this video is of the eye movement. Is that fine? Please confirm that you are able to see my screen. Hello?
Yes, sir. Yes.
Yeah.
Yes, sir.
Yes.
So now you can see this particular person. This is about a 5-minute video, but I'll play slowly. So this is how we do the Dixarpec. We turn the head to one side. Okay. We turn the head to one side. And then this is a full Ipley maneuver. Okay. With the method that I showed you for the right side. Now we see we have taken the person down. When we were taking the person, now when the head stopped, can you see the right upbeating torsional to the right? You can see the upbeating torsional to the right. And then just see this video answers the question how long you're supposed to wait. Okay, this video itself answers the question how long you're supposed to wait. It's a totally a 4.28 minutes video. So I've been waiting here. Okay. Now what I do is see 1 minute and 14 seconds over. Okay. I'm still there in that position. I wait for long and long so that the debris gravitates. Okay. Again, there are studies which tell that debris takes different amounts of time. Okay. Different amounts of time. Very small debris can take some hours also. But most clinical practice, if you wait for about 2 minutes, that is good enough. 3 minutes is maximum. Okay. Beyond 3 minutes, I don't think there will be any great benefit. Okay. Between 1 and 3 minutes. Okay. Can you see this? The same upbeating torsional nystagmus reappeared in this position. What does this tell is, it tells that the debris has been moving in the same direction. If the direction of debris had changed, you would not have got this same direction nystagmus. If the same direction nystagmus that you got when you took it to the Dixalpine position, see here back, I'm just going back into the Dixalpine position. What I got in the Dixalpine position, this same nystagmus, once we started doing this method, we started seeing this more frequently, this thing. Okay. And when you see this, when I turn the patient now up around 2 minutes, between 1 and 3 minutes is the ideal time. Okay. No extra benefit more than 3 minutes. Less than 1 minute, maybe 2. See here again upbeating torsional, which tells that the debris has been flowing in the same direction, which is the ampulofugal direction. Okay, I'll come to that, what exactly this means and all of these things again. And from here, I make the person sit up. Okay, now I'm waiting for a long time here because it is about 2 minutes and 27 seconds. Okay, now I'm making the head almost like a flat. Okay, previously it was nose down. Here it is almost flat. And then we make him sit up and nose is facing down. Because the couch is on the other side, the sitting up. That is why now you are seeing the back of the head. Okay. So this is how we do. So now this is the jumping time. Okay. This is the jumping time. Can you see the jumping we are making? Okay. So this is how we do this thing. So the previous one was the method. This is the thing. Now, let us ask a few questions. Okay. So I think all the questions are being answered here. What all are here? Can we use tilt table for posterior canal? Of course, you can use a tilt table if you have a tilt table and the neck is bad. Okay. Can we do Dixalpine in those with cervical radiculopathy? Any corrections to be done? Within the limits of the patient that he allows, you can do. Okay. But there, I do see a lot of cervical radiculopathy patients and I do this thing. In anterior canal, we add chin up. That is right. I've answered the question. How long should the person be kept in each position? That question is answered. How long after a maneuver is it appropriate to retest again? I will come to this. Okay. Can we use a tilt table? Of course, if you have a tilt table, definitely you can use. How long should we wait in each position? This is answered. How much time the patient should be? Everything is the same question, all of them. Okay. Sir, do we have to make the patient jump with the chin tucked? Yes. When the chin is down, I mean, not exactly tucked, but little down, about 30 degrees, you know this, I have shown the thing. Okay, I'll just show the screen again. I'll show the screen again. So when you see here, when the head is pitched little forward, that is the time you see this common crus is most vertical. So that common crus being more vertical is very important for the debris to finally fall off. And at this stage, if you jump in place, the chance of that just by deceleration, by sudden deceleration, the chance of that falling off is very high. Okay. Is that question okay? Fine. Now I will come to the other questions. I stop the sharing. So there was a question here. When can we do retesting for the canal? Like for example, if you have done a proper repositioning, there is a question that is asked, when can you do retesting? Why is this question? Okay. So the question, the meaning of this particular question is there a possibility that this particular debris, which I have right now removed, is going to, and put it back into the utricle, is there a possibility that I will push it back? Okay. Is there a possibility that I'm going to push it back? That is the most important concern when you're going to do that. Okay. When it comes to Simont maneuver, we do back-to-back Simont maneuvers 2 times, 3 times, back-to-back, without waiting, which is actually equivalent to doing a Dixalpike test immediately. So now the key question here is not when you are going to do the repeat Dixalpike test. Most of the time, when you are going to do the repeat Dixalpike test to confirm whether it has been cleared or not cleared, most of the time is actually determined by our OPD practice, how many patients we have. It is more about like we see one more patient and then come and recheck. By then, our hope is that it will resettle. But if we know what to expect, then you can start rechecking immediately. You can start rechecking immediately. What is this? What to expect? What is the fear that you had? The fear that you had is you have removed the debris. It has come and fallen into the utricular cavity. Is it going to go back now into the posterior canal? Or is it going to go from the common crus into the anterior canal? Okay, this is our fear. This is exactly our fear. So now we will answer this question. So we all know, okay, there are 2 ways in which, okay, I'll just again reshare the screen. There are 2 ways in which we identify, okay, I think last time we covered the belt drive mechanism. If required, I'll again cover that again. Okay. When you see this particular image, so there is 2 possibilities. The first one was when the patient came to you, when you did the initial Dixalpike test, the debris started coming from here and started going down like this. Now, if you had succeeded in doing the proper Ripley and it had came to this green area, which is the utricular cavity, now there is a possibility that it is going to go back here and enter the posterior canal and enter the anterior canal. That is our biggest fear. Now the question here is very simple. Can we recognize it if it is going to enter the anterior canal? Can we recognize it if it is going to enter the posterior canal? The answer is yes. So when you do the Dixalpike test in the starting, this debris moving like this produced an upbeating nystagmus. If you remember from the belt drive mechanism, if the flow happens like this, the circulation is like this, the eye also will rotate in the same direction, which means the front of the eye will go down and it will produce an upbeating nystagmus. Whereas if the debris started off from here and it started going into the posterior canal from here, that will become a downbeating nystagmus. If when you did the examination first, you had a proper posterior canal BPPV. If you had a proper posterior canal BPPV and you cured it, in the next step, when you are repeating the Dixalpike maneuver, if you don't get any nystagmus, you have cured it. No problem. Okay, if you don't get any nystagmus, you have cured the person. No problem. That is success. If you get the same upbeating torsional nystagmus that you got during the first step, That means the debris is still here, it had not come out, and therefore you are getting that particular thing, which means you should do the EPLI again. But if you start getting a downbeat nystagmus, the moment you put the person into Dixalpike position, that means you had succeeded before. Now we are messing up by repeating it, and now it is entering. Now, what is the answer? The moment you notice downbeat nystagmus, immediately make the patient get up, put the nose down, and jump. That's it. That is the answer. So, how do you interpret the second? When do you do it? More than when you do the repeat Dixalpike, how you interpret the repeat Dixalpike is very, very important. Okay, this comes from the analysis and study analysis done by Dr. Balamurugan. Okay, he has done an excellent analysis of this one to tell. So, after the next Dixalpike, same like first Dixalpike it comes, you didn't cure, your EPLI did not cure, he needs a repeat EPLI. If there is no nystagmus, you have cured and everything is fine, no problem. If it starts becoming a downbeat nystagmus, you had succeeded, now the success is being messed up. It is like you write the correct multiple choice question first time, and then on second thought we change the answer and that becomes wrong. It will become like this. You have done it well, now it was well, let it be well. So the answer to the moment it starts becoming downbeating, immediately make the patient get up and don't repeat the Dixalpike. Don't repeat. You had cured him. You can always call him after 48 hours for a re-evaluation. Okay. So this is about when to test this thing. Okay. Now it can also enter the anterior canal. Okay. From here in the Dixalpike, it is not that it should enter only the posterior canal. It can also enter the anterior canal. Okay. It can enter the anterior canal. Now, how do you identify that it has entered the anterior canal? In the anterior canal, when you put this, we all know that the nystagmus of anterior canal is upbeating or downbeating. We all know for the nystagmus of the posterior canal is
Upbeating.
Upbeating. Nystagmus for anterior canal is
Downbeating.
Downbeating. So nystagmus for anterior canal is downbeating because in most of the time when we are doing the test, the debris was situated somewhere here where I'm showing my cursor. Okay. And that starts going in this direction, which rotates the wheel here like this. The eye also rotates like this, which means the front part of the eye comes up and it beats downwards. So it is going to be a downbeat nystagmus here. Okay. It becomes a downbeat nystagmus. That is for this direction movement. This direction movement of the debris is exit direction movement. Exit direction movement means this is the ampulla. The debris has to go all the way like this, like this, like this, and then exit outside through this into the utricle. Okay, that is exit direction movement. Entry direction movement will be for anterior canal. Will it be downbeating or upbeating?
Upbeat.
Hello? It will be upbeating.
Upbeating.
Entry direction will be upbeating. And so it is a reversal. And entry direction nystagmus is a complete opposite. It's a complete opposite of the exit direction nystagmus. Exit direction nystagmus was downbeat and torsional to the affected side. Whereas entry nystagmus will be upbeat and torsional to the other side. Now let us put all the things together. You have done your Dixalpike test. You did a diagnosis of posterior canal BPPV. Then you are doing a repeat Dixalpike test. Possibility number 1, no nystagmus. Excellent. You have done a great job of your EPLI maneuver. Possibility number 2, upbeating nystagmus, torsional to the same side as before. Torsional to the same side as before. You are not cured. You need a repeat EPLI maneuver. Possibility number 3. Possibility number 3. You are doing a Dixalpike test. Now, you are getting a downbeating nystagmus. the debris has started entering the posterior canal, please don't wait. Immediately make the person sit up, or immediately make the person prone and sit up. That is how you are going to stop that. Okay, depending on how long you waited. If you waited really long, then you may have to prone and sit up. Otherwise, simply make the person sit up and keep the head as down as possible so that it will come back. Okay, keep the nose as down as possible. Okay, keep the nose as down as possible so that even if it had gone little further also, it will keep coming down. This is what we are supposed to do. The last possibility is that it has entry into the anterior canal. See, the typical posterior canal exit nystagmus was upbeating. This is also going to be upbeating. But the exit nystagmus was upbeating torsional to the same side or the affected side. Here, the torsional will be to the opposite side. If it is becoming torsional to the opposite side, that means it is started entering the anterior canal. Then also the solution is immediately make the patient sit up. Immediately make the patient sit up. This is the key in both of these things. So now you interpret. Now you know how to interpret the post-maneuver Dick-Salpike test. Pre-maneuver Dick-Salpike test is different. Post-maneuver Dick-Salpike test is different. Okay, is that clear? Hello?
Yes. Yes, sir.
I didn't stop sharing. Were my slides actually seen so far?
Yes, sir, it is seen.
Yes, sir.
Okay. Because I got a doubt whether I was simply talking with, imagining that I'm looking at the slides. Okay, fine, great. Okay. So now I want to show something more. Okay, I'll just see the questions and then we'll see. Okay. How much time patient should be in each position? That is answered. Do we have to make the patient jump with thin tuck chin forward? That question answered. Do we need to recheck if the particles have moved into the utricle? Okay. Now there is a question about, okay, Bhavana ma'am is asking any post-maneuver restrictions. That also we'll try to answer in a scientific way. Okay. In multi-canal BPPV, you have to wait between maneuvers, or we can do all the maneuvers one
Hello?
after the other. Okay. In multi-canal BPPV, yes, somebody is asking question. Yeah. In multi-canal BPPV, do we wait between maneuvers? Definitely for both the doctor and for the patient, a 10-15 minute gap between maneuvers is definitely good. Okay. Is definitely good. A 10-15 minute gap between maneuvers is definitely good. Now coming to post-maneuver restrictions, what kind of restrictions is good? Okay, let us go to that one. There is a question about restrictions. So again, I'll go back to my slides. Now, this is one more thing that we need to know. Okay. This is a frontal projection of all the semicircular canals. Okay. So we are very familiar with the top-down projection. We are very familiar with the this is from the top view of the semicircular canals that we see. Okay. Okay. But this frontal projection is so beautiful and so important for us in the sense to understand a lot of things that happens in these semicircular canals. Now just see what happens in all of these semicircular canals. You will get some beautiful insights in this particular semicircular canal. Okay, that one is the doom of, this is the ampullary part of the anterior canal. This is the ampullary part of the lateral canal. This is the ampullary part of the posterior canal. All of these things. And when you see here, when the debris moves into all these places, all these, if you make the person lie down on one particular side, if you see one particular side, if the person is lying down on the right side, okay, on the right side, from the frontal view projection, you can see most of the emptying parts of the canals are the lowest. The emptying parts of the canal are the lowest. For the left side, On the right lateral position, the emptying part are at the lowest. Okay, you can consider that as entry part also. Okay, you can consider that as entry part also, but emptying part is the lowest, means from here, the lowest means it has to really move against gravity to go up. Okay, so this empty entry part is the lowest part, which means if it has to enter, it has to really go against gravity to enter this. These are the open ends. These are the closed ends. The blue things, the ampullary part, we all know, we saw from the last lecture, that these are the closed ends of the canals. So it cannot enter from the closed ends. Okay. So these things, if it enters from here, whatever, so it has to really work against gravity to enter the semicircular canals. So we can possibly conclude based on this much that it is a good idea to be on the unaffected lateral side. To be on the unaffected lateral side. That is number 1 point. Number 2 is this one. Okay, this diagram. Okay. When you see this particular diagram, if you see, sorry, I'll just show this diagram. Okay. When you see this particular diagram, when you see the canals empty into the or entry, both of them is in the posterior part of the utricle. It is in the posterior part of the utricle. Because if it is in the posterior part of the utricle, if the person has a nose down, then this debris will likely to be going front and forward and then second. Okay, forward and then settle down so that it does not come back. If at all you want to give a restriction, a limited restriction, if at all you want to give a limited restriction, the patient can sleep on the unaffected side, number 1. Can sleep on the unaffected side. Number 1 point is that one. Second point is, this can be even better demonstrated from a top view also. See from the top view. See here, top view. This is the front part. This is the front part. And these are the areas which are all medial. The emptying parts are all medial. If the person sleeps on the unaffected side, they all go there. All the canals are in the anti-gravity position. Therefore, the entry will not into the other canals is less likely. So you can sleep on the unaffected side. That is number 1. Okay, especially if you are not sure you are cured, because this will ensure that it will cure. The last few debris will enter. If you are 100% sure that you have cured, then putting the person's nose down, okay, nose down will ensure that I'll just show it properly. Okay. Nose down, if you put the person into nose down position, it will ensure that all of the debris that has entered the utricle will gravitate downwards. That is the place where the actual utricular macula lies. And here there is no fear of entry into the short arm of the posterior canal. There is no entry into lateral canal, and there is no entry into anterior or posterior canal. Okay, fine. So the things that I was telling about repeat Dick-Salpike test, they are also true. They are also true when you are actually doing the posterior canal BPPV also. So when you are actually doing posterior canal Ipley maneuver also, sometimes it is possible that it will enter the anterior canal on the other side. This is a very common observation. This is a very common observation. The common observation is somebody is trying to treat the anterior canal BPPV, posterior canal BPPV. It starts exiting. At some point of time, it will start entering the anterior canal. This is where people tell, sir, I did Dick-Salpike right. I got upbeating torsional. I did Dick-Salpike left. I did not get anything. Next, I did Dick-Salpike. I was doing the Ipley maneuver. When I was doing the Ipley maneuver, I started off from the right. I got upbeating torsional to the right. The moment I turned the patient face to the other side, like 90 degrees, that is the second step of Ipley. Upbeating continued, but the torsion became opposite side. When the torsion becomes opposite side with the upbeating continue, only two possibilities are there. One possibility is that opposite side posterior canal is also affected, or this side anterior canal entry has happened. This side anterior canal entry has happened. So that is how you are supposed to interpret. If that happens, what you are supposed to immediately do is, if it has started entering the anterior canal, don't allow you to go full beyond it. Immediately make the patient sit up and you get a cure. Immediately make the patient sit up and you get a cure. So what we are trying to do here is, instead of a same technique of maneuver, okay, you wait for some time, you go to the next step. Instead of that, we are watching, and each new nystagmus is telling us something that is happening in the traffic. It is telling what or where the debris is going. Based on that, you are going to see. So if you're doing a posterior canal BPPV, throughout, if you're getting the same upbeating torsional or no nystagmus also, no problem, then you continue the test in the same way. The moment it starts becoming downbeating and torsional reversal, that means the debris has gone back. Then you'll have to go back and then restart. Okay. If you start getting downbeating torsional to the opposite side, the debris has started going back, and then you have to go back and retrace the steps. What is going back and retracing the steps? Like, for example, if you started, what is going back and retracing the steps is, for example, if you just started off with Dixal pike like this, and then you turn to the other side, now you start getting a downbeating with the torsion reversed. That means the debris has started going in the opposite direction. For right posterior canal, it should be upbeating torsional to the same side. If it becomes downbeating and torsional to the other side, that means the debris has started going back. The debris has started going back, you should trace back your steps. What is tracing back your steps? You have moved to another next step of the apli. No, you have to go back to your previous step of the apli, wait for some more time. If required, we do what is called washerman technique, means give some bangs to the head or some shake to the head so that it starts coming down, and then retrace the steps so that your success rate increases. Okay. Now, if you turn to the other side and then suddenly it starts becoming an upbeating torsional to the opposite side, it is an indication that immediately you have to make the person sit up, because there is, especially if the first Dixal pike on the left was negative. If the first Dixal pike on the left was negative, once you turn to the other side, if you start getting torsional to the other side with upbeating continuing, you have to make the patient get up. Same problem can happen, okay, when during repeat Dixal pike test also. So this is how we come to conclusions. Okay, so next question here is, I'll take some more questions here. I think Dr. Joshua is asking, can you explain after maneuver assessment, eye movement explanation? Okay. I'll come to that, sir. If the patient has left posterior canal and right lateral canal involved in later stage, no complaints, what should be done in rehab? If it is reversed, there is no need to do any rehabilitation if everything has been okay. Okay. If the patient has been cured, there is no need for any rehabilitation. Okay. Because what you cured the patient, that itself is rehabilitation. Okay. This is from Kalyani Joshi. Posterior canal and right canal involved, and in the later stage, no complaints. That means this patient is cured. What could be the reason for reversal of nystagmus? Same position. This I will take. Okay. All questions I will take one after the other. So upbeating torsional in the same position becomes downbeating. So there are multiple explanations that are given. So I will tell you one after the other all the explanations. Okay. So the question here is, the question from Ganavi is, sir, I did a Dixal pike test. I first got an upbeating nystagmus and torsional to the right. After some time, it started becoming downbeating and torsional to the left. What is the explanation? There are multiple explanations that are given. I do a lot of chair rotation experiments. When you do chair rotation, when you sit in one particular position in a chair and start rotating the chair to the right, after about 5-6 rotations or 7-8 rotations, though I am still rotating to the right beating nystagmus which started when I am rotating to the right, which is appropriate, after some time starts becoming a left beating nystagmus. After some time, it starts becoming a left beating nystagmus. If you do a caloric test and if you wait long enough, the nystagmus that was beating in, say, right beating, after some time starts becoming left beating nystagmus. What are the explanations for this? With here, there is no debris, here there is no debris in two locations, nothing. It is simple physiological stimulation which is causing a biphasic pattern of nystagmus. Now, there are two things that are possible. One thing is, in the initial movement, the cupula got deflected, and now the cupula is springing back opposite direction. It can spring back in the opposite direction. Whichever direction the cupula is deviated, that is the kind of nystagmus that you expect. Okay. For a cupula deviation in one direction, if you get one nystagmus, for the cupula springing back into the opposite direction. So it was pushed and now it is springing back. Second thing, second explanation is that this being a very strong and inappropriate nystagmus, inappropriate means generally a nystagmus is physiological and it is supposed to give good vision or clarity of vision. There is a possibility that the brain was generating an opposite tone to reduce this nystagmus. And after some time, so this is like the inner ear is driving the eyes to beat nystagmus in another direction. The brain has generated an opposite tone to suppress it. But after some time, the drive from the inner ear settles because the debris stops, but the tone continues and the nystagmus in the opposite direction starts coming. Second explanation. Third explanation, there is actually debris in two locations, and in the beginning, one location debris started moving, and in the other location, debris started moving late. I will explain that using the diagram. Okay, just I will show you this one. In this diagram, if the patient had debris in two locations, there was a debris here and there was a debris here. In the beginning, this debris predominates and it produces upbeating torsional nystagmus to one side. And afterwards, this one starts moving. Okay, very near the common crus and little beyond this. Okay, near the dome of this canal. There are special names also given for this. From here, the next debris starts moving. And in which case, this will be generating the opposite nystagmus. All the three are possible. All the three are possible. Most of the time, it will be the first two explanations is my bias. It's my personal bias. Okay, rather than this thing. Because a lot of my own friends also believe that it is possible that is the debris in two locations. So my bias is that it's more of either a cupular spring back. It got pulled like this when the debris was moving. The cupula was pulled in one direction. After some time, the cupula spring back to other direction. Or possibly it was the opposite tone generated by the center, that is the cerebellum, which starts, which gives the opposite directed nystagmus. Okay. I'll take more questions. Then I will come to Dr. Joshua's question that needs a little bit detailed explanation. How we know whether it's going in anterior, opposite, posterior canal is involved. Got the answer. He got the answer. Samir sir. In multi-canal BPPV, how should repositioning maneuvers be performed to avoid intercanal conflict? See, there is really no pure way in which you can do a maneuver in which two canals don't respond. The reason here is, in every plane that you see, in however you do, you can't really stop the other canal's debris from moving. Okay, you really can't do it. Okay, had we had a magnet and this was magnet sensitive, okay, instead of calcium carbonate, if it was something ferrite, and then probably we could drive it in a particular way, but otherwise this is not possible. So the best approach so far is that deal with one canal at a time. Deal with one canal at a time and then do. So you can deal with posterior canal and then do the lateral canal, or you can do the lateral canal and do the posterior canal. Posterior canal, entering lateral canal is quite common. So ultimately you will have to again do the lateral canal also. So you can choose this thing. For me personally, there is nothing to choose between lateral and posterior canal as of now. It is empirical. Maybe in the days to come, I'll come up with something which strong reason why to choose one maneuver first over the other maneuver. Maybe which is more symptomatic is deciding which one I attempt now. Can lateral canal convert to anterior posterior? Definitely, anything can convert to any canal. So what we need to do is, biggest conversions is posterior can become short arm posterior, posterior can become lateral, and posterior can become what is called anterior also. Anything it can happen. The best approach, nose down. Once you have cleaned, if the nose down, the chances of things entering other canals is very low. In BPPV, do you always get nystagmus? If patient feels vertiginous but no nystagmus, this problem is more when you are doing BPPV with naked eye. Okay, with naked eye, we see very commonly no nystagmus at all. I have personally verified that multiple times. Okay, so just for the sake of my curiosity, though I have all the goggle, everything, once in a while I do test without the goggle. And when I test without the goggle, it's so very often happens that we don't see nystagmus. Okay, so it can be. That is where these goggles become advantageous, so that they actually start showing the nystagmus. Okay, and the chances of missing out something is very low. Okay, but even with goggles also, small debris BPPV, there will be 1 or 2 beats, but you have to be very attentive that 1 or 2 beats to catch. Under the constraints of time and after confirmation with particular canal, do we have to use VNG goggle for corrective maneuver, for transition check? The best way is to use the goggle, because what happens is, this is like this. So we used to do septoplasty before. Okay, we used to do septoplasty before. Now we are doing an endoscopic septoplasty. Is there a difference? Definitely there is a difference. Okay, it is like that. Now you know what is happening, especially when the head is down, prone. Okay, what exactly is happening? That finesse is possible with the goggle, especially after you have diagnosed. The finesse that the goggle gives, the confidence that the goggle gives, and that the joy that it teaches you something about physiology is too much. So if you use goggle, it will be great, at least for the first time. Then second, third time, it's okay. There are patient-related issues, too much obese, too much. Then sometimes I just skip it. But most of the time, the way we do it is with the goggle. Rehab exercise in BPPV, I don't give any rehab exercise in BPPV after maneuver. It's not manicure, it's maneuver. That's autocorrect in your autocorrect in your keyboard has to be disabled, Dr. Sunil. Okay. Manicure is a different procedure. And they charge more than us. Sir, at times when we do Dixalpike test, on right side, there is no nystagmus detected. However, when we do McClure-Pegnini test on the right side, there is a torsional nystagmus. Yes, this can happen. There are 2 things there. Last time I was mentioning what happens in this thing. First thing here is, okay, there is a planar anatomy on all of these things. Yes, true. First thing is about horizontal canal producing some amount of torsion. Okay, or some amount of torsion, which can be confused as posterior canal. Number 1 question. Second possibility is, it's actually posterior canal. It didn't show in Dixalpike, but it started showing in the lateral position. Okay, it started showing in the lateral position. So when you see this, in the course that we teach, there is one statement that I make in the course, or that is there in this thing. Are the canals actually completely in one plane? They are not in one plane. Within that plane, there are tortuosities. There are bends in these canals. Evolutionarily, why these bends, what purpose they serve, we don't know. Okay, but there are bends. So if it is not, if one bend in the posterior canal, I'll just take the diagram again to show. Okay, or before going to the diagram and coming back to your question, I'll take other questions and then come there. Okay. Can patient have bilateral posterior canal? Of course, we can have posterior canal bilateral BPPV, and we treat one after the other. When it is a bilateral posterior canal BPPV, if both inner ears are simultaneously affected in posterior canal, you have to suspect a vertebrobasilar insufficiency. Because why should both ears be affected together? Unless there has been an end, like a watershed area, there has been some amount of reduction in blood supply. It may be very distal, very minimal, not help any, not cause, because brain has such beautiful auto-regulation, it was not known. But in the inner ear, the distal modes parts underwent some amount of some duration of ischemia. That is why both sides. So we need to be sure. If somebody comes with bilateral posterior canal BPPV, look for atherosclerotic vascular disease. Look for any urinary tract infection or anything which is causing sepsis and low blood pressure. Even ask for any gastroenteritis or something that has happened which made them dehydrated. All of these things. These things are, or there must have been a trauma. So bilateral posterior canal BPPV our antenna should be up to look for all these things. Okay. Autocorrection. Yes, it's Manohar, I know, Sudhi. Okay. And I told also, we charge less. Manicure people charge more. So how do you address that, Dr. Sumit? Is that you do one canal after the other. Okay. Are there any predisposing factors that should be looked into in patients with direction changing nystagmus, as it is observed only in a small set of patients? So what did you mean by direction changing nystagmus? Okay. Now I told, okay, for example, okay, you can just write that down, what exactly you meant by direction changing, because we do see this quite commonly. Okay. It is about how long you observe these things. For us, it is quite common. In the sense, if you talk about upbeating becoming downbeating after some time, we do it. Okay. We do see this. It is not that uncommon. Okay. We do see that. So that is why the physiological explanation, I tend towards more of the physiological explanation rather than debris being in multiple locations, though that is also possible. Okay. For how long after the first maneuver can we retest? I think we just answered that question in quite detail, that we can retest immediately, but how to interpret the retest is the biggest chunk of our discussion that we did. As long as you know how to interpret it, fine. So I gave you the 4 interpretations. Okay. Now coming to in our practice, we wait about 15 minutes before retest. Okay. 15 minutes minimum we wait. Okay. So if you want to know what is our practice. Fine. So I'll come to Shivani's question right now. Shivani's question was, and then again I'll come back to the chat box and then take other questions. So, now some difficulty in navigating between applications. Yeah. Yeah. So coming to Dr. Shivani's question is something like this. Her question was, in the Dick-Salpike test, in the Dick-Salpike position, you get nothing. And then you do macular pectini and suddenly you start seeing the same posterior canal type of nystagmus. Okay, that was her question. So see this. Okay, see this. There is a possibility that what did not move. Okay, when you see these areas, okay, from the frontal side, when you see, okay, this is where you get a beautiful idea. And from the top side also, when you see, you will notice that this one, okay, this one, it is quite possible that if you overextend the neck or whatever here, okay, there is quite a possibility where was this? Okay. See here. Okay. From here, it need not move up. Okay. If the debris is somewhere here, it need not move up and it need not come down. Can you see this? Okay. It need not, it should move up and it should come down. It need not. Whereas in the lateral position, it is quite possible that it simply starts moving down like this. Is that fine? So this is what I was trying to tell, that these canals, okay, these canals, and see from the top, okay, from here also, of course, posterior canal, down view would have been nice. But the key principle here is these canals are not in one plane. So what we think as a good test in a particular plane is not. I have seen the opposite also. I have seen lateral canal nystagmus not showing up in the maculaire pegnini, but showing up in the Dix-Alpine test. That is because these canals are not throughout in the same plane, and there may be a location at which another canal's plane is a better plane for this location in this canal. So it is like that. It belongs to, because of the canal not being in a single plane throughout. So that is the explanation. Okay. Hope that is clear. What is the direction fixed lateral canal BPPV? It's quite simple. There is no need to get overworked up about that. If you, okay, in the last session, first session, I was talking about what is called a therapeutic direction nystagmus. A therapeutic direction nystagmus for a lateral canal, if the right lateral canal is involved, the therapeutic direction nystagmus is left beating. Okay, its therapeutic direction nystagmus is left beating. This is the thing. Now, if you got a patient in whom, when you started off, there was a left beating nystagmus, okay, on the right lateral position, there was a left beating nystagmus. Now from there, if you go to the supine position, if the debris starts moving in the correct direction, it will continue to be left beating. When you go to the left side, it will continue to be left beating. That's all it is. It means you are getting a cure for the patient. Okay. If you get a direction fixed lateral canal, my only suggestion is, if you are rolling the patient to the left and you are getting a left beating nystagmus and you think it is direction fixed, only suggestion for you is just put the patient prone also. The patient will get cured. Patient will get a cure. That means the debris is moving in the correct direction of therapy. Okay. So that is the only meaning. Any extra maneuver needed for lateral canal BPP? Nothing. Same old maneuvers that we have been doing. You have a Guffoni maneuver, you have a barbecue roll maneuver, you have a Zuma maneuver, and we have a Appiani maneuver. These are the only maneuvers. All of them are available on my channel. Just go through them and you can do this. I always suggest that you finish the first part, because we covered a lot of these concepts of therapeutic direction, curative direction, nystagmus of therapeutic direction, and nystagmus of curative direction. All of these things, if you do, then some of these confusions will not be there. And the first part is also available. Link is available on my YouTube channel. Okay. These things. Now coming to, I think Dr. Joshua was asking a question, interpretation of these nystagmus, like the repeat Dix-Alpine test, where it enters and all of these things. See here, there are two things here. Okay. So again, I will just, for those people who are new to the concept of belt drive mechanism, this will be something, okay, something as a, it is new, but for other people, maybe it's a revision. So I will just do that. Okay. So in this particular thing, okay. If this is the posterior canal, if you imagine a wheel in the posterior canal or in the anterior canal, anywhere, okay, you can imagine a wheel. And if you imagine that there is a wheel within the eyes, if this is the eye with the cornea in the front and this is a wheel, okay, if this is a wheel, you can think that the two wheels are connected by a belt drive. You can imagine that these two wheels are connected by a belt drive. Now, if you imagine these two wheels are connected by a belt drive, if there is a debris that is here, which starts moving in this direction, this will rotate this wheel like this. The rotation of this wheel in this direction will make this belt to move like this and will make this wheel rotate in this direction. If this wheel within the eye rotates in this direction, eye goes down like this. This going down, pay attention here. This going down is the slow phase of the nystagmus because vestibular phase is the slow phase. Now the person is going to have a upbeating nystagmus. Okay, this direction flow, upbeating nystagmus. Opposite direction flow will be downbeating nystagmus. Okay, opposite direction flow will be downbeating nystagmus. Let us imagine for the anterior canal. For the anterior canal, again, if you imagine this particular belt drive and there is this eyeball. Okay, so if this is the thing, this is a very, very strong concept. Once you start becoming familiar with the belt drive, you will start predicting what is going to happen to the patient in the clinic and it is going to look magical. Okay, so now if this is the thing, in the head down position in the anterior canal, you know that the debris moves like this, correct? Because in the head down position, this is the gravity. This is when it starts moving like this. Okay, when it starts moving like that, this wheel is moved in this direction. So this wheel rotates like this, which means this belt goes in this way. This wheel rotates like this. So the eyes go up and the beat will be down. So downbeat nystagmus. So whenever the debris is exiting the posterior canal, you will get an upbeating nystagmus. Whenever the debris is exiting the anterior canal, you get a downbeating nystagmus. Hope that concept is clear. Now what I will do, the torsional component. Let us now try to see what happens to the torsional component. Is that okay? So for the torsional component, you see here, this is the beauty that I want all of you to understand. The posterior canal on the right side, it's something like this. Okay. So the posterior canal on the right side, it goes like this. Okay. You can notice this. This is the posterior canal. The anterior canal on the right side, okay, it starts off. I'll just write outside. Okay, actually, it should be little below the level, but I'm just writing outside. Like this, the ampulla, and then it comes like this. This is the common crest. Is that fine? This is the anterior canal. So you can see the anterior canal here. Okay, so we saw the posterior canal and anterior canal. Now, what was the previous thing? Exit direction. Exit means away from the ampulla. When the head is down, okay, exit direction away from the ampulla would be in this canal. Also, it is like this only. In this canal, also, it is like this only. Okay, so it is like towards the common crest. So here also you can see it is towards the common crest. So here exit is. Can you see here? The exit is towards the common crest. The exit here is towards the common crest. Now, if you go here and write those towards the common crest, if you start drawing these diagrams, okay, I will redraw this for clarity. So, if this is towards posterior canal, if it is towards the common crest, and anterior canal also it is towards the common crest, both the wheels, the posterior canal wheel or the anterior canal wheel, both these wheels will rotate in this direction only. Now, when these wheels are connected to the eyeball, okay, when this wheel is connected to the eyeball, what will happen is from the front, okay, this is the eyeball wheel. This will move this belt in this direction and the eye will go like this. Upper pole of the eye will turn to the opposite side and the beat will be towards the same side. And the beat will be towards the same side. Same thing happens for this one also. Same thing happens for this one also. It is the same direction. So, ampulofugal flow for anterior canal and for posterior canal will produce the same kind of torsional beat that is towards the affected side. That is towards the affected side. This is exit. Okay. This is answer to Dr. Joshua's question. So this is exit direction. Now, if it is entering the anterior canal on the same side, what will happen? The torsion will become ulta. The torsion, instead of beating towards the same side, will start beating towards the opposite side. Entering the anterior canal, exiting the anterior canal was down beating. Entering the anterior canal will become up beating. So, if during your Dixalpic or Epley, suddenly you notice that the nystagmus has started becoming upbeating and torsional to the other side, it has started entering the other, on the same side, anterior canal, especially beginning opposite side Dixalpic, if it was normal. Especially if the beginning opposite side Dixalpic was normal, this is what is going to happen. So, that is how. If it starts becoming downbeating and torsional to opposite side, that cannot be explained by entry into anterior canal. That can only be explained by reverse flow in the same posterior canal. Reverse flow in the same posterior canal. Just keep this. I will just have Dr. Preeti I will share this presentation with Dr. Preeti. I think we will put it in the groups so that whoever wants to play with these things, draw your own diagrams and then come up with conclusions, whatever you can do that. Is that okay? I think that answers Dr. Joshua's question also. I'll go back to the chat box. That's it. I think no more questions are there. If I by mistake left any question, please ask that again or unmute yourself and ask me. Okay. Ma'am.
Yes, sir.
Anything more? This is almost 1.5 hours.
It didn't feel like 1.5 hours.
Yes.
Thank you so much for that. I think all of the
People have got used to 4 hours after the movie started becoming 4-hour movies. So 1.5 hours is nothing now. Yeah. Yes.
But I think you have answered so many relevant questions and the common doubts.
Yes,
I
ma'am.
think it's a very informative session.
Yes, ma'am.
So is there any other questions that any of the participants wants to ask? Or shall we call it a day today?
Again, I will make this also available on YouTube because sometimes lot of the discussion will become overwhelming in the first go. Okay, at some point of time, we may feel lost or whatever. So you can always go back from there and start listening again. Okay.
Yeah, some of them have to be processed a little more slowly. I think.
And with the slides shared, I think we'll put them in all the groups. I don't know whether we have all the phone numbers to be sent because we didn't have a registration or anything.
Yes,
So
yes.
we can just put it in the. I will share this immediately after this presentation, this keynote as a PDF, so that they can start using it, or as a PowerPoint. I'll convert it in PowerPoint because most people can play with the slides if it is a PowerPoint. Okay.
So thank you so much, sir. I think,
Thank you.
every time we listen to you, we're learning something new. And
Thank
I think BPPV is always, it never ceases to surprise us every other time.
Two key messages was that we observing the nystagmus throughout will tell us what is happening to the debris, and it should be the same nystagmus throughout, telling that it is going in the correct direction. If it is not going, how to interpret it? So that is the message. The next key message is possibly if the side affected is right, lying down on the left side is a good practice, and being prone is a good practice.
So thank
Yes,
you so much, sir, for your valuable time. So
Thank
on
you.
behalf of AOI Kochi and Cochin Neurotology Club, a big thank you.
Thank you, ma'am. Thank you so much.
This time, and thank you to all the participants.
Thank you.
sir.
Thank you, sir. Thank you so much.
Thank you all. Thank you so much. Thank you for joining. It's a honor.
Thank you, sir.